Hi guys, what's up? Let's do some work today. So today I'm beginning the fundamentals of nursing, and the first topic I'm treating is fluids and electrolytes. This area is very important in the NCLEX. I will be looking at pertinent areas that the NCLEX wants you to know. I have just 3 slides for you, but these slides have very important information, which I encourage you to have a pen and paper and you take down some notes. I will not go into details of the slide. I will just mention particular areas that concern the NCLEX. Let's get started. Okay, we know that our body needs fluids and electrolytes. And when we have a deficit of fluids and electrolytes, it affects the cardiovascular system, the respiratory system, the skeletal system, and the neurological system. I want you to take note of this. Now, in this case, we have these electrolytes that are very important that we need to know: sodium, potassium, calcium, magnesium, and phosphate. Okay, phosphorus. Now, you have to know these values. In this present NCLEX, you don't need to memorize the value because when they give like case study questions, they give the values there. But in single questions, they will not give the values. If they want to test your knowledge on lab values, so in other words, I will encourage you to know the values. Okay, sodium is 135 to 145, potassium is 3.5 to 5.0, calcium is 9.0 to 10.5, magnesium 1.3 to 2.1, phosphorus is 3.0 to 4.5. Now pay more attention on potassium. A potassium above 6 is a critical lab value. You have to report, you have to take action. Very, very important. Now, let's look at, I made mention that our system needs fluid. Our system needs this electrolyte. So when we don't have this electrolyte, when we don't have fluids, we have what we call fluid volume deficit. Okay, and the goal is to replace the fluids and to eliminate the cause so that we have fluid electrolyte balance. Now, we can have electrolyte imbalances, for example, fluid volume deficit by hyperventilation, ketoacidosis, early kidney disease, diabetes insipidus. Which one is that? It's a type of diabetes that is not caused by insulin. It is caused by simply over excretion of fluid through our kidneys. Chronic malnutrition and ostomy. When somebody has a colostomy or ostomy, what happens? Fluid is lost through the GIT through this ostomy, right? What happened? You're bound to be left with less fluid volume deficit. So when this happens, we can present with increased pulse, training, orthostatic hypotension. So you look at each system, what can be the effect? Orthostatic hypotension is when there's a great difference in your blood pressure when you lie down, when you sit, and when you stand. So they ask you to do orthostatic blood pressure measurement. We find someone with fluid volume deficit with flat neck, decreased central venous pressure, poor skin turgor. These are simple things that we know. What happens when we have fluid volume excess? What do we say? Overhydration, or we say fluid overload. It could be caused by what? Congestive heart failure. This is a heart disease condition where we have fluid retention. So when we have a lot of fluid ascites, this fluid is bound to accumulate, and we have in all this condition coming in place. Wound irrigation. Don't be confused with ostomy and wound irrigation. Wound irrigation is you cleaning the wound, so you are instead giving more fluid to the skin. It can instead result to fluid volume excess. Okay? Water intoxication, when you overtake in hypotonic fluid, like in drowning, little kids they drown, you have excess fluid. Early kidney disease, chronic kidney disease, the kidney cannot excrete fluid very well. It's bound to return, and you can have much fluid in your system. And you can present with what? Decrease urine-specific gravity. You have edema, you have pale skin, you have skeletal muscle weakness, crackles, there's much fluid in your system. You have elevated central venous pressure. The pulse is bounding increase. In fluid volume deficit, the pulse is trading, increased pulse. In fluid volume excess, the pulse, when you check, it will be bounded up. Of course, there's more fluid inside, right? You can actually feel. You have altered mental stages, visual disturbances when there is excess fluid in the system. We have to know this. What I want you to pay more attention is, let's look at this slide once more. Let's go to potassium. When we have less potassium, meaning less than 3.5, we have hypokalemia, right? And we've seen the causes. It could be vomiting, right? Diarrhea, excessive suctioning, like somebody who is on tracheostomy. Maybe so diuretics can also help to over-excrete sodium and potassium. Now, you want to treat this condition by replacing potassium. I said, when you have a value that is too low, below 3.5, you have to replace with potassium IV free. But you have to be careful. There are conditions for you to effectively administer potassium IV. Okay? First, you must assess the renal function before you administer potassium. Make sure that you are administering at an infusion rate of 5 to 10 milliequivalent per hour at a maximum of 20. You can never give potassium more than 20 milliequivalents per hour. Okay? Never give potassium by IV push. No. Subcutaneous, IM, no. It is only IV, and you have to use an infusion pump because you have to measure the rate that is going. It has to go at a slow rate because potassium burns the veins. It burns the veins. So always dilute potassium with 0.5 normal saline when you're administering. Make sure that you label the IV bag. So let it clearly show that this is potassium infusing. Okay? The patient has to be on a cardiac monitor, and we have to monitor the I and O's, input and output. Okay? Now, potassium can cause infiltration. It can cause phlebitis. So what happened? Always monitor the IV side. And when you notice phlebitis or infiltration, stop the infusion immediately and keep the vein KV, keep vein open. Okay? That is very, very important. You have to know that. Now, specifically, if you have less potassium, right, hypokalemia, you have to give what? You give a potassium sparing diuretic. That is a diuretic that is retaining potassium. So, but if you discover that the patient was on potassium losing diuretic, you instead have to stop it. You must know these two different: potassium losing diuretic and potassium sparing diuretic. You have to be very careful. But now, when we have excess potassium, let's say above 6, this is a critical value. This patient is a critical case. You have to monitor. Like we said, this patient should be on a cardiac monitor, and you check for dysrhythmia because it can cause cardiac changes. This is a life-threatening condition which can lead to cardiac arrest. So you have to do cardiac monitor carefully. Immediately discontinue the IV and keep the vein open. We hold any oral potassium that is going, and please, very, very important. If it's severe hyperkalemia, means severe potassium, right? You can administer IV calcium in order to avoid myocardial excitability. It's very important. Most importantly, always you will have multiple choice questions. They ask you, always make sure the patient is on a cardiac monitor, check for cardiac dysrhythmia, and monitor input and output, all of that, like I said before. This is very important. Let's look at another electrolyte, calcium. Calcium is very important. Now, if we have low calcium, we have hypocalcemia. If we have high calcium, we have hypercalcemia, right? But now, I do not bother to look at the causes, like I said, they're almost the same. But how can you manage hypocalcemia? We have to administer medication that can increase calcium absorption, like what? Aluminum hydroxide. What happened? It reduces phosphorus level, thereby increasing calcium level. We're going to say, we say phosphorus and calcium, they are reciprocal, meaning when one is going high, the other one is going low. When one is going low, the other one is going high. So they work in opposite direction. You have to be careful. Seizure precaution if somebody has less calcium level. Seizure precaution. I said electrolyte, they have effects on our skeletal system. This patient can have pathological fractures. But when the patient has excess calcium, hypercalcemia, you have to do what? Immediately stop the IV infusion. If calcium was ongoing, was infusing, stop oral vitamin D that the patient has been on. You have to strain the urine to check if there are some urinary stones. This is what you do. Let's look at magnesium, very, very important. There is something I want you to know. Again, let's say low magnesium is hypomagnesemia. High magnesium is hypomagnesemia, okay? And when you have low magnesium, always make sure you initiate seizure precautions. You monitor deep tendon reflexes. Why? When you have hypomagnesemia, what happens? You start a magnesium infusion. Maybe the value is too low, right? But there can be a consequence. When you over-infuse this magnesium, it gives what they call hypermagnesia, which you will have to monitor. If you start noticing that this patient has deep tendon reflexes, you have to stop this infusion. This is a sign of hypermagnesemia. Very, very important. Very important. So, but when we have hypermagnesemia, we can give calcium gluconate. We can administer calcium chloride. Calcium gluconate is an antidote for magnesium, for high magnesium levels in our system. Calcium gluconate. Very, very important. Phosphorus. Now, I want us to look at something. What can be the changes of this electrolyte on the ECG? There are questions that they always ask in this area. Increase or decrease electrolyte can cause significant changes on the ECG. Now, for us to understand this, there is something I want us to memorize. For potassium, I say the direction for you to know if it is low potassium, everything goes low except for heart rate and urine output. That's why I say the same as the prefix, except for high rate and urine output. Meaning, if it is hypokalemia, everything is low. Constipation set in. Of course, the GI system is not functioning well. But what? Only the high rate, the heart rate, and the urine output will increase. If it is hyperkalemia, means increased potassium, everything is high, except the heart rate and urine output will be low. Now, don't bother yourself with all this ECG stuff, right? We're not doing ECG right now, but I want you to have a view of how a normal ECG rhythm looks like. PQRX, right? This elevation here is a P, it gives this V, opposite V, the QRS, and then it goes there, give a T, elevated T, right? The normal, there's a curve there, the T. Knowing this, how a normal ECG rhythm looks like. Let's look at hypokalemia. We say everything goes low except for heart rate and urine output. It means in hypokalemia, we have a flat or inverted T wave. You see here, it is inverted. Instead of being the normal T wave here, it means everything goes low. ST depression, we have the ST segment here. Is normal here. But what happened? It goes down, it depressed, everything is down. Hyporeflexia, muscle weakness, lethargy. So when you're selecting, it comes in multiple choice. Look at everything that's going down, those you select those ones, except for the heart rate and urine output. Hypokalemia, increased potassium, everything is up. Tall peak T wave, you see here, it's very tall. The normal one, you just have a normal curve, but in excess potassium, it's very tall, it goes high. So when you see tall peak wave, then it is hypokalemia, agitation, diarrhea, the GIT is overacting. Boborygmy, what's that? Don't mind the big words. They're talking of hyperactive bowel sound. Okay? That's it, what is talking, the rumbling and rolling sounds in the stomach, in the intestine. That's what I'm saying. Abdominal sound. You see, boborygmy. Spastic muscles. But what happened? The heart rate and urine output is decreased. Widening QR complex. So when you see, they say hypokalemia, everything is high, except for the heart rate and urine output. Let's look at calcium. We said it is opposite. So when you see hypocalcemia, it means everything now is high. You have prolonged ST segment, prolonged QT interval, increased heart rate and urine output, hyperreflexia, positive Vostek and tracer sign. Hypocalcemia. For magnesium and calcium is opposite. If it is hypo, everything is high. If it is hyper, everything is low. So, most importantly, I want you to know this sign. Let me show you this picture. Hypocalcemia. Positive Vostek sign means when we touch the facial nerve here at the corner of our ear, we will have a contraction of our facial muscles. When you touch here, if somebody has hypocalcemia, there will be that twitching sign. When you touch, the face will move, okay? When you tap the facial muscle here, the facial nerve, sorry, so the face will twist this sign. But tracer sign, when you apply a blood pressure curve and you inflate it, your hand will curve. It either goes this or it goes down, whichever is tracer sign, like what you're seeing there. Apply a blood pressure curve here and inflate it above the systolic blood pressure value. You see the hand twist like this. It will go down. There's carpal spasm. Either it goes up or it goes down. These are the changes. These are the effects of low calcium in our system. I'll come back to hypomagnesia. Now, if we have high calcium, hypercalcemia, everything is low. So you have shortened ST segment. When you look here, our XT, the ST segment here, but here it is prolonged. It is shorter. Up is prolonged, here is shorter. And what happened? The T wave is widened. You see, hypoactive reflexes, constipation, everything is low. Same with magnesium. Now, take home for magnesium. When we have hypomagnesemia, one important ECG changes that we'll find is what they call tauset de pointe. It's a French word. This is very important. In NCLEX, they always ask on this. The ECG changes that we notice when someone has hypomagnesemia, tauset de pointe. If you don't want to know anything, know this. It looks like this, some type of ECG changes. This is an effect of hypomagnesemia. Okay? This is very, very important. I want you to know that. Now, for sodium, instead, the second I want you to know for sodium is hyponatremia. You see the O there. I put a capital O there. When we have hyponatremia, we have fluid overload. Overload. Fluid overload. So you have to look at the signs and symptoms of fluid overload. When we have hyponatremia, you see right there, the capital E means dehydration. Dehydration, fluid volume deficit. So you look at the signs and symptoms of fluid volume deficit, of dehydration, that will be caused by excess sodium. Fluid volume excess is caused by low sodium, hyponatremia. I explained before, right? So we have looked at that and wanted to look here one more time. There are some, multiple choice questions like in nursing school. They always ask you, you have to know when to give a phosphate binder, right? When we look at when you have low phosphorus in your system, what do you do? When you have high phosphorus in your system, you say you have to take a phosphate binder. What does it do? Like calcium carbonate, several calcium acetate. What happens is that it binds with calcium, it brings calcium in the physis, and then you eliminate it through physis. Yes, that's how it works, because you have excess phosphorus in the system. You want to send it out. And that is it. That is it. So I want you to know this, guys. This is very important. I leave you with this and see you again in my next video. If you know this video is important, let me know. The next video I will make, I will do question and answers on this. I could not include questions here, it would be too long. I wanted you to have a view, a knowledge of fluids and electrolytes and important areas to pay attention. And then when we answer questions, they will help you to understand the questions as quick as possible. Okay, that's it. Okay, see you guys in my next video.